Yes, sir. Can you see my screen?
Yes. Can you just move your pointer so that we know that you have a, can you move your cursor and,
Can you show the screen moving, slides moving?
yeah, we can see the slide moving, but can you just make sure that your, go to full screen and just make sure that your pointer is moving so that you can, while describing the pictures, you know that what you're talking about. We know what you're talking about.
Sir, let me check. I have done full screen, but it's not presenting on screen sharing. Sir, can you see the slides moving now?
Yeah. I can see the full screen. You're on full screen mode. Just make sure that that your pointer is working as well.
Yes, sir. Okay. So shall we start, sir?
So just let me do a brief introduction and then we can start. So I welcome you all to yet another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. The idea behind the session is to establish and develop 3D neuroanatomy, which is very important for any neurosurgeon or neurosurgical procedures. The topic of today's presentation is deep cerebral veins. Dr. Daniyal is third-year resident neurosurgery at Liaquat National Hospital. I would like to introduce our expert panelist today. Our expert panelist today is Dr. Rimal Hanif Dossani. Dr. Rimal is a neurosurgeon in Florida with interest in cerebrovascular and skull-based neurosurgery, including endovascular. Dr. Rimal, we are honored to have you on board. Thank you for giving us the time.
Thank you.
Doctor.
Thank you, Dr. Khan. Good to be here. Assalamu alaikum to everyone.
Thank you, Dr. Rimal. So, Dr. Daniyal, can you start your presentation?
Yes, sir. Hello, assalamu alaikum, everyone. So today's topic of presentation is deep cerebral veins. Discussing about the deep cerebral veins, the deep venous system collects into channels that courses through the walls of the ventricles and basal cisterns, and these converge on the internal cerebral, basal, and great veins. These veins drain the deep white matter and gray matter surrounding the lateral and third ventricles and the basal cisterns. The deep veins are divided mainly into two groups, that are the ventricular group and the cisternal groups. So discussing about the lateral ventricular veins, the ventricular veins are divided into medial and lateral groups. The ventricular veins drain into the internal cerebral basal or great veins, as I have previously told. The lateral group consists of anterior caudate and thalamo-striate veins in the frontal horn, the thalamo-striate, posterior caudate, and thalamocaudate veins in the body, the lateral atrial vein in the atrium, and inferior ventricular vein and amygdala veins in the temporal horn. This is an image, superior view of ventricles showing the green colored are the lateral ventricular group veins and orange colored are the medial ventricular veins. The anterior caudate vein is in the lateral wall of the frontal horn, and thalamostriate vein is present in the lateral wall of frontal horn and the body of the lateral ventricle. The thalamocaudate vein is also present in the lateral wall of the body of the lateral ventricle. Uh, the lateral atrial vein is present in the uh, atrium, and inferior ventricular vein and amygdala vein are present in the temporal horns. The medial ventricular veins are formed by the anterior septal vein in the frontal horn, the posterior septal veins in the body, the medial atrial vein in the atrium, and transverse hippocampal veins in the temporal horn. This image, as in this image, we can see the anterior septal vein, the posterior septal vein that is present in the body and the medial wall of the lateral ventricle, the medial atrial vein present in the atrium, and the posterior longitudinal hippocampal vein and anterior longitudinal hippocampal vein, in which the transverse hippocampal vein drains. This is another view, the lateral view showing the veins, ventricular veins, medial and lateral groups, the anterior septal vein, the anterior caudate vein, the posterior caudate vein, the posterior septal vein, the thalamocaudate vein, medial atrial vein, and the lateral atrial vein that is present in the atrium, and it drains the lateral side. This is another view. This is anterior view showing the posterior caudate vein, anterior caudate vein, medial atrial vein, lateral atrial vein, the transverse hippocampal vein that is present in the temporal horn, the inferior ventricular vein, inferior choroidal vein, which drains into the inferior choroidal vein, and amygdala vein, which drains in also into the amygdala vein. So now discussing more specifically about the ventricular veins. In this diagram, this is the anterior view, and this is the inside. The arrow is showing the frontal horn and body of the lateral ventricle. This is the anterior view. The frontal horn is located anterior to the foramen of Monro and has the septum pellucidum in the medial wall. The body of the lateral ventricle has the thalamus in its floor. The caudate nucleus is in the lateral wall. The body of the fornix and the septum pellucidum is in the medial wall, and corpus callosum is in the roof of the lateral ventricle. The choroid, this is the choroid plexus that is attached to the choroidal fissure. Now discussing about the veins, this is the anterior septal vein that cross the roof and medial wall of the frontal horn and join the and it passes posteriorly towards the foramen of Monro, where they join the anterior end of the internal cerebral veins. The anterior caudate vein, we can see this is the anterior caudate vein, which crosses the lateral wall of the frontal horn and join the thalamostriate vein. And then it passes through the foramen of Monro. We can appreciate the superior choroidal vein, which courses on the choroid plexus in the body. The posterior septal vein, which crosses the roof and medial wall of the body and pass through the margins of the choroidal fissure. This is the posterior caudate vein, and it crosses the lateral wall of the body, and it joins the thalamostriate vein. This is the posterior caudate vein, and it joins the thalamostriate vein. We can also see anterior superficial thalamic vein and superior superficial thalamic veins here. Anterior and superior superficial thalamic veins cross the surface of the thalamus. This is another image. This is the anterior superior view, and we can follow the arrow in the inset, and we can it depicts about the body, atrium, and occipital horn of the lateral ventricle. We can appreciate there is calcar avis and bulb of the corpus callosum. That this is the bulb of the corpus callosum, and this is the calcar avis, and it forms the medial wall of the atrium and the occipital horn. The floor of the atrium is formed by the collateral trigone. The roof and posterior part of the lateral walls are formed by the tapetum of the corpus callosum. Caudate nucleus is present in the lateral wall. In this image, we can appreciate the medial and lateral atrial veins. This is the medial atrial vein, and this is the lateral atrial veins, and they pass forward on the medial and lateral walls of the atrium towards the choroidal fissure. We can also see a thalamocaudate vein which crosses toward in the lateral wall, and it is posterior to the thalamostriate vein. This is the thalamocaudate vein, and this is the thalamostriate vein. The superior choroidal vein is also present, and it courses towards the foramen of Monro. In this is the posterior view, and the arrow in the inset shows the atrium and the temporal horn, and this is the posterior view. Here we can appreciate the inferior choroidal vein, and it courses on the choroid plexus in the temporal horn. The lateral atrial veins are also present, and it arises on the lateral wall and crosses the tail of the caudate nucleus. This is the tail of the caudate nucleus, and this is the pulvinar. So the lateral atrial veins pass through the tail of the caudate nucleus and pulvinar to pass through the choroidal fissure. We can also see medial atrial veins that pass forward, and it penetrates the crus fornix near the choroidal fissure to reach the quadrigeminal cistern. The other vein is transverse hippocampal vein that crosses the floor of the atrium and the temporal horn. This is the arrow in the inset shows the anterior view. In this image, the arrow in the inset shows the anterior view into the temporal horn. The floor of the temporal horn is formed by the collateral eminence and hippocampus. The roof and lateral wall are formed from medial to lateral by the thalamus, the tail of the caudate nucleus, and the tapetum of the corpus callosum. We can also see the amygdoid nucleus that bulges in the anterior medial part of the temporal horn. This is the pes hippocampus, that is the bulbous digitated anterior end of the hippocampus and is in the anterior part of the floor. The choroid plexus is attached to the choroidal fissure. The inferior ventricular vein, we can see here the inferior ventricular vein, and it drains the roof of the temporal horn and it receives the amygdalar vein from the ventricular surface of the amygdoid nucleus. The inferior, we can see the inferior choroidal vein, and inferior choroidal vein joins the inferior ventricular vein. We can also see the transverse hippocampal vein in this diagram, and it drains the floor of the temporal horn and passes medially through the choroidal fissure and it to enter the basal vein or its tributaries. Now discussing specifically about the internal cerebral vein, that is the important vein in the ventricular group of veins. These are the paired internal cerebral veins originate just behind the foramen of Monro and course posteriorly within the velum interpositum. Initially, they follow a convex upward curve of the stria medullaris thalami, and distally as they course along the superior lateral surface of pineal gland's body, they follow a concave upward curve of the inferior surface of the splenium. And the union of the paired veins to form the great vein can be located above or posterior to the pineal body and inferior or posterior to the splenium. This is the image of the internal cerebral vein in the roof of the third ventricle. This is the superior view of the frontal horn and the body. In this view, we can see the foramen of Monro, the fornix that forms the superior and anterior margin of the foramen of Monro. We can see the thalamo-striate veins and superior choroidal veins, and also we can appreciate the choroid plexus. The thalamo-striate and superior choroidal veins converge on the posterior edge of the foramen of Monro. In this diagram, the fornix has been folded backward to expose the tila choroidea. We can see the tila choroidea and the internal cerebral veins in the roof of the third ventricle. We can also see the anterior septal veins, anterior septal veins medially, anterior caudate vein laterally, the thalamo-striate vein, posterior caudate vein. In this diagram, the internal cerebral veins have been separated to expose the branches of the medial posterior choroidal artery. We can see the medial posterior choroidal artery. And also we can appreciate there is tila choroidea present. Tila choroidea forms the floor of the velum interpositum in the roof of the third ventricle. In this picture, the lower layer of tila has been opened and we can see the pineal gland, the posterior commissure, and the massa intermedia. This is another diagram And in this diagram, the upper part of the hemisphere has been removed to expose the frontal horn, the body, and atrium of the lateral ventricle. The choroid plexus is attached to the along the choroidal fissure. In this diagram, we can see the expanded part of choroid plexus in the atrium of ventricle, and it is known as glomus. In this diagram, the body of fornix has been removed, and now we can appreciate the veins more clearly. These are the internal cerebral veins, the thalamo-striate veins, anterior septal veins can be seen, superior choroidal vein, the lateral atrial vein that comes through the choroidal fissure, and it drains in the distal part of the internal cerebral vein, the medial atrial vein, the basal vein and internal cerebral vein joins to form the vein of Galen. And we can also see the part of calcarine sulcus has been removed, and we can see the anterior calcarine vein. In this view, this is the posterior superior view of the ventricles with the upper part of the cerebral hemisphere removed. In this, we can appreciate the anterior caudate veins laterally, the anterior septal vein medially, lateral atrial vein, posterior caudate vein, internal cerebral vein, thalamo-striate vein. The internal cerebral vein joins the basal vein and it forms the vein of Galen, and that continues as the straight sinus. There we can see the calcarine sulcus. Laterally, there is a prominence of the calcarine sulcus that is known as calcar avis, and it is present on the medial part of the atrium. This is an enlarged view of the previous diagram. We can see the internal cerebral veins and the basal veins, internal cerebral, the lateral atrial vein drains in the internal cerebral vein, the internal cerebral and basal vein joins to form the vein of Galen, and that continues as the straight sinus. We can see the pulvinar and the choroidal fissure from where the lateral between the pulvinar and the Femoria arises the lateral atrial vein, and it goes to drain in the internal cerebral vein. We can see the choroid plexus and the anterior calcarine veins posteriorly. In this diagram, we can see the inferior ventricular vein that arises between the lower part of the pulvinar and the femoria, and it courses forward and it drains in the distal part of the internal cerebral vein. This is again an enlarged view of the inferior ventricular vein, and it passes through the choroidal fissure located between the femoria and the lower surface of the pulvinar, and it goes to drain in the internal cerebral vein, and that internal cerebral vein then joins with basal vein. Now the second group of veins are the cisternal veins. The cisternal group of deep veins drains the area beginning anteriorly in the front of the third ventricle and extending laterally into the sylvian fissure and backward to include the walls of the chiasmatic, interpeduncular, crural, ambient, and quadrigeminal systems. In this diagram, this is the anterolateral view. This is the insert that is showing the frontal and temporal lobes have been retracted away from the floor of the anterior and middle cranial fossas. In this image, we can see the basal vein. The basal vein is the most important vein in the cisternal group of ventricular veins. So here we can appreciate the basal vein and the important tributaries that drain here in the basal vein are the deep middle cerebral vein and anterior cerebral vein. Anterior cerebral vein and deep middle cerebral vein joins to form the basal vein. The two anterior cerebral veins are connected with anterior communicating vein. We can see in this diagram the anterior fossa, middle fossa, the uncus, temporal lobe, frontal lobe, occipital lobe. The another important vein that drains in the basal vein is the fronto-orbital vein. This is the fronto-orbital vein that drains the orbital gyri, and it then further courses in the basal vein. Another important branch is the olfactory vein that drains the gyrus rectus, and it then further courses and drains in the basal vein. This is the anterior perforated substance, and inferior striate vein is another important vein that exits the anterior perforated substance, and it drains in the basal vein. Below the basal vein, there is another important vein that is known as peduncular vein, and it drains in the uh, basal vein. Now in this image, this is the lateral view from the right side, and in this image the temporal lobe has been retracted, as we can see in the inset. This is the tentorium that extends along the side of the brain stem. The basal vein passes around the brain stem. This is the basal vein, and it continues, it joins with the internal cerebral vein, and it forms the vein of Galen. In this image, we can see the basal vein, and the important vein in this diagram that is the internal occipital vein and the posterior pericallosal veins that drains into the basal vein. The basal vein then joins the internal cerebral vein to form the vein of Galen. From above, the inferior sagittal sinus comes, and vein of Galen and inferior sagittal sinus joins, and they continue as the straight sinus. In this image, this is the right anterolateral view with the anterior portion of the right cerebral hemisphere is removed. In this, the anterior cerebral veins joins the deep cerebral veins. This is the internal cerebral vein. It joins the basal vein to form the vein of Galen. We can also see below the vein, basal vein and vein of Galen, the superior Vermian vein, in which drains the superior hemispheric vein of cerebellomesenteric fissure, and tactile veins that drains into the basal vein from below. This is the inferior view of basal cisterns. The basal veins are formed below the anterior perforated substance. This is the anterior perforated substance, and basal veins are formed by the superior sylvian vein, the deep sylvian vein, superior sylvian veins that joins and forms the basal vein. In this is another view. This is showing the uncus. The uncus has anterior and posterior segments. In this diagram, the part of the posterior segment of right uncus and adjacent parahippocampal gyrus has been removed. We can see the anterior and posterior parts of the basal vein. This is the temporal horn. We can see the longitudinal hippocampal vein, the femora, and the choroid plexus in this image. This is the enlarged view after removal of the femora, the large veins draining the roof of the temporal horn, and we can appreciate the inferior ventricular vein that drains into the basal vein. In this diagram, the choroid plexus has been removed. This is the peduncular vein, the basal vein, the inferior ventricular vein, the lateral atrial vein that all drains in the basal vein. Both the basal vein and internal cerebral vein comes, they join and they form the vein of Galen. From laterally, the anterior calcarine vein drains in the distal part of internal cerebral vein. In this diagram, this is the inferior view of the frontal lobe and anterior perforated substance, and in this picture, the optic chiasm has been retracted. We can see the anterior cerebral veins that are connected with anterior communicating vein. This is the anterior communicating vein. This is the anterior cerebral vein. The deep sylvian veins joins the anterior cerebral veins and they form the basal vein. In this image, we can appreciate the paraterminal veins. The paraterminal veins joins the anterior cerebral veins and anterior communicating veins, and it then goes further along, crosses the optic tract and forms the basal vein. This is another enlarged view of the basal vein. We can see the paraterminal vein, anterior cerebral vein, the deep sylvian vein that joins and forms the basal vein. In this diagram, we can see the superficial sylvian vein, the deep sylvian vein, and the olfactory veins. They, along with anterior cerebral vein, they converge and they continues and forms as the basal vein. In this diagram, we can appreciate the basal vein that traverses along the cerebral peduncle. This is the crural part of the basal vein, the ambient part, and the quadrigeminal part of the basal vein. In this diagram, we can see the posterior longitudinal vein, posterior longitudinal hippocampal vein after removal of the part of the temporal horn, and anterior longitudinal hippocampal veins. In this picture, we can appreciate the choroid plexus. Above that is the lateral and atrial vein that passes through between the femora and the lower part of the pulvinar. We can see the basal vein. We can this is the uncus, and it is drained by the uncal vein. This is again a picture showing the deep sylvian veins, the superficial sylvian veins, the anterior cerebral veins that continues and forms the basal vein. This is the crural part. This is the ambient part. This is the quadrigeminal part. The inferior ventricular vein that drains in the distal part of the internal cerebral vein. The anterior calcarine vein that drains along the junction of the internal cerebral vein, basal vein with the vein of Galen. Now this is a lateral view showing the internal cerebral vein above the thalamus, and this is the basal vein above the posterior cerebral artery. They continues and join to form the vein of Galen. In this view, we can appreciate this is an enlarged view, posterior superior enlarged view. The inferior ventricular vein drains in the basal vein, and it then continues to form the vein of Galen. In this picture, we can see the internal cerebral veins along internal cerebral vein along with the basal vein. This is the peduncle, this is the crural part, ambient part, and the quadrigeminal part of the basal vein. In this image, we can see the formation of vein of Galen, which is formed by joining of the convergence of the anterior calcarine vein, internal cerebral vein, basal vein, and the superior vermian veins, and it forms the vein of Galen, and then vein of Galen continues as the straight sinus. Thank you.
Thank you, Dr. Daniyal, for that detailed presentation. I would now like to request Dr. Rimal to give his experts comments and share his cases. Dr. Daniyal, can you stop screen sharing so that Dr. Rimal can share his cases?
Dr. Daniyal, that was a very good presentation. Very nice discussion of the deep venous anatomy, and really appreciated your classification of the deep venous system into the cisternal and the ventricular aspects. And I think once, with the anatomy, one of the most important ways to remember the anatomy is to have classifications in mind so that you don't get lost. And when you have these classifications, especially for the deep venous system of the ventricular system and the cisternal system, it will help you remember at least the major veins. And then as you become more expert in neuroanatomy, you will pick up some of the more subtle and the smaller veins as well. Thank you very much, Saad, for having me in this conference here today. It's very impressive participation. Are most of the participants, are they residents in training?
Yeah, most of them are training. Majority of our participants are not from Pakistan, they're from abroad.
I am trying to share my screen here.
Dr. Daniyal, have you stopped screen sharing?
Yes, sir, I will stop.
So Saad, just give me 1 second. I'm using an Apple, and it's asking me to quit and reopen. I had to go into my system preferences. So if you guys could just give me 1 minute, I'm going to quit and reopen and join again.
Okay, that's okay. So during that time, if there's any questions that you guys want to ask, you guys can use the chat box. Next week we will have posterior cerebral arteries that will be presented by Dr. Priyanka. Please use that chat box to give us feedback about the session. How would you like to improve it? anything that you guys would like us to do, maybe a topic, a presentation. So this is the time we really get time to interact. So if there's anything that you guys wanna say, or say stuff that can improve the sessions, this is the time till Dr. Rimal join back. I see that we have Dr. Flores from Bolivia. Thank you, Dr. Flores, for joining the session. I hope these sessions are of help to you. Imad, can you please make him co-host again? Dr. Rimal, if you can hear me, you're a co-host now. Can you share your screen if possible? Yeah, we can see screen sharing. Yeah, we have you on board.
Can you hear me, Saad, now?
Yeah, we can hear you.
So looks like we're on board now. Thank you for working out the kinks. I'm not going to go through the lesson again that Dr. Daniyal shared, but this is a broad overview of the important superficial and deep venous veins. Within the ventricular system, we have the internal cerebral vein, and then we have the septal vein that goes medially, and then the thalamostriate vein that goes laterally. I would say these are probably the three most important veins within the ventricular system that carry the most anatomical relevance. And then within the cisternal segment, especially in a subtemporal approach, the basal vein of Rosenthal is the most prominent vein in the ambient cistern, and that carries a lot of relevance. And then obviously the vein of Galen, which is also known as a great vein, carries relevance with respect to pineal region surgery. I have two cases I'd like to demonstrate. These are classical neurosurgery cases, and something that I'm sure everyone will encounter at some point in their career. I was fortunate to encounter them early on in my career. And this is a lady, is a 50-year-old, presented with headache, nausea, and vomiting with deteriorating vision over the week prior to presentation. She had no focal neurological deficits. She was awake, but she had some confusion. And this is her CAT scan. And it would be good to get participation from the resident. Since Dr. Daniyal presented, do you want to explain the findings on the CT head here, Dr. Daniyal?
Daniyal, can you explain? Yeah. So, Dr. Rimal, most of the participants are muted. They can use the chat box. Only the co-host.
Sounds good. Sounds good. So I'll keep going here. So this is a CT head here, axial cuts that demonstrates a lesion in the region of the foramen of Monroe associated with hydrocephalus. And then the picture on the right demonstrates this case came into one of my senior neurosurgical colleagues, and he temporized the patient and stabilized her during her presentation by putting in ventriculostomy in each of the frontal horns. And then he consulted me for a definitive resection of this colloid cyst. This tumor in the foramen of Monroe region measured about 2.5 centimeters It's one of the larger cysts that I've seen, considering my training and fellowship in brain tumor and cerebrovascular neurosurgery. And when I encountered this, I thought of a number of various approaches to resect this particular lesion. Certainly, this is a intraventricular lesion in the region of the third ventricle, with the fornices displaced superiorly, and the internal cerebral veins displaced superiorly and posteriorly, as can be seen on the lateral projection here in the sagittal view on the right. There are various approaches to tumors and lesions in this location. The most traditional approach is intrahemispheric transcallosal, but then there are other more practical and more straightforward and easier approaches from a technical standpoint that include transcortical microsurgical approach, and in the more modern era, transcortical endoscopic approach. Here's a recap of the anatomy that Dr. Daniyal had shared with us. This is an identical image to one that he had shared with us, demonstrating the anatomy of the lateral ventricle in the coronal plane. We can see that just above the foramen of Monro is the fornix, and hidden underneath the fornix is the internal cerebral vein. The choroid plexus can be seen heading towards the foramen of Monro. And there are two very relevant anatomical veins that carry importance with respect to the location of the choroid plexus relative to the foramen of Monro. The vein going medially is the septal vein, and the vein that goes laterally here is the thalamostriate vein. And both of these veins are tributaries of the internal cerebral vein. The reason why these two veins are particularly important is when you're in the ventricle, it's important to know which ventricle you're in. Are you in the right ventricle or are you in the left ventricle? And the way to know that is to look at the relationship of the thalamostriate vein to the choroid plexus. So if the vein is to the right of the choroid plexus, then you're in the right ventricle. If the vein is to the left, then you're in the left ventricle. This is another schematic demonstrating the cyst in the third ventricle and the associated anatomy. This is the lateral ventricle in the coronal plane. This is the cyst, the internal cerebral veins displaced superiorly and posteriorly, and the fornix that is displaced superiorly. I elected to, because the right frontal horn of the lateral ventricle was so large, and fortunately the right-sided ventricle was the larger one, I ended up going through the non-dominant right frontal hemisphere. I used the transcortical microscopic approach, and I made about a 3 centimeter horizontal incision centered at Coker's point, about 10 centimeters from the glabella and 3 centimeters to the right of midline, essentially the same entry point as you would use for the ventriculostomy. I left the ventriculostomy in place, and then I followed the ventriculostomy all the way down to the frontal horn of the ventricle, and then I just placed a Greenberg retractor medially. I did not want to place a Greenberg retractor laterally because, as Daniyal mentioned, that's where the caudate head of the nucleus is. So if you're going to put a retractor in the right hemisphere, just put it medially. And then once you're in there, then you can introduce the microscope, and you have a great view of the lateral ventricle. This approach to me was very practical. The approach was only 3 centimeters deep. It took only 10 minutes to really get into the ventricle, and with the retractor in place, you have a great view of this enlarged and dilated ventricle. From a technical standpoint, once the cyst is identified, the first thing to do is to get into the cyst and quickly debulk it. And then the real surgery comes in place once you have to dissect the cyst wall from the surrounding veins and the fornix. And the technique that I find easiest here is to not try to go for the whole cyst wall. Just try to take the cyst wall that comes easily. I just try to grab the cyst wall with the suction, and then it becomes a matter of just coagulating whatever residual cyst is in the wall of your suction coagulate it, and then cut it. And then whatever comes out, you remove it. Try not to be too aggressive, because remember, the cerebral veins are located just behind. And most of the time, if you take off enough of the cyst wall, chances of recurrence are really low. So this is the post-op MRI, demonstrates gross total. No residual cyst wall is identified. The cerebral veins are noted to be intact, and so are the fornices, as you can see there. This is a CT head that was obtained and delayed follow-up. There is no recurrence of the cyst, and the ventricular anatomy has essentially returned to normal anatomy, as you might see in a normal patient. All the dilation and the hydrocephalus has resolved subsequent to resection of the cyst. This patient did not require ventriculoperitoneal shunting and is now back to her baseline. Does anybody have any questions relating to this case?
If you have any questions, please write your questions in the chat box, and Dr. Rimal will be happy to answer those questions.
Okay. Thank you. In the interest of time, I'm going to go ahead and present my second case here. This is another classical neurosurgical case with a classical diagnosis. It's a young patient, 21-year-old, presented with headaches and worsening vision. On neurological exam, he was awake and alert. He had an upgaze palsy, but otherwise, he had no other cranial nerve deficits. His pupils were reactive. This is his MRI in the sagittal and coronal plane, demonstrating hydrocephalus, enlarged ventricle size. And the key feature of the hydrocephalus here is that it's triventricular hydrocephalus. The fourth ventricle is normal, but the lateral horns and the third ventricle, you can see, is really dilated. And there's a lesion in the region of the pineal that is compressing the aqueduct of Sylvius, contributing to this triventricular hydrocephalus. This lesion is almost uniformly enhancing, with a couple areas of necrosis in the middle there. With respect to workup of these pineal tumors, the standard of care is to send for serum and CSF markers, especially in younger patients, because a lot of times these tumors can be positive for markers, including the three main ones are placental alkaline phosphatase, beta human chorionic gonadotropin, and alkaline phosphatase. Elevation of AFP suggests endodermal sinus tumor or diagnosis of a teratoma, and elevation of beta HCG suggests germinoma or embryonal cell carcinoma. There are various approaches to pineal region tumors. There are entire textbooks that are written just on pineal region surgery. I think the most common ones are, especially in the modern era of neurosurgery, include endoscopic third ventriculostomy and endoscopic biopsy, along with CSF sampling for those tumor markers like we just discussed. The reason why this approach is important is because this is the least invasive of all the approaches. And the reason to do this particular approach is for young patients, especially male patients, the majority of the time, the diagnosis is going to be germinoma in this region. And if the biopsy comes back as germinoma, then those tumors, it is the only pathology in the pineal region that does not require gross total resection. It is highly amenable and responsive to radiotherapy, and that is the standard of care. And that is why the first step in management of these tumors, especially those that present with hydrocephalus in young patients, and especially young male patients, is to perform an endoscopic biopsy. And while you're there, you can do a third ventriculostomy to reduce the need for ventriculoperitoneal shunting. And the reason to avoid ventriculoperitoneal shunting in these patients is there is a concern for seeding from the ventricular space to the peritoneal space. And so if the CSF is positive for tumor cells, now by putting a shunt in, you're spreading the tumor and causing it to metastasize from the brain to the abdominal cavity. So endoscopic third ventriculostomy is practical, one, because you're already there to perform the biopsy, and two, it prevents the possibility of tumor seeding. The other more common approach, I would say from an open neurosurgical approach, this is the most common one. It is the one that was promoted and advocated by Dr. Roten, and we're all familiar with his anatomical textbooks, and we saw some of his pictures today, anatomical illustrations and cadaveric dissections. And that approach is a supracerebellar infratentorial approach. And the third more common approach with respect to resection of these tumors is the parietal intrahemispheric. And surgeons who do a lot of pineal region surgery will choose between the supracerebellar infratentorial versus the parietal intrahemispheric approaches just based on the venous anatomy on the MRI and what approach will cause the least disruption of these critical venous structures in the deep venous system. So I ended up doing an endoscopic third ventriculostomy with an endoscopic biopsy. And I wanted to highlight the relevant anatomy. And Dr. Daniyal had shared some of this anatomy here. We can see the foramen of Monroe, the choroid plexus, the septal vein, and then the thalamostriate vein. So once you put your endoscope into the lateral horn of the frontal ventricle, you see this anatomy, you can recognize that you're going to be in the right frontal horn of the lateral ventricle. And then you pass your endoscopic camera through the foramen of Monroe, and then you're going to be in the third ventricle. And once you're in the third ventricle, this is the view from inside the third ventricle. Posteriorly, you'll see the midbrain, which is where the tumor is located. So in our case, once we got into the third ventricle, we were not able to see the midbrain. We saw this large pearly tumor. And then anteriorly, you have a number of very eloquent structures. You can see the columns of the fornix, the anterior commissure. Below the anterior commissure, you can see the lamina terminalis. And the lamina terminalis we can see from a subfrontal microscopic approach as well. And it connects the optic chiasm to the anterior commissure. There's a large recess, open space, directly above the optic chiasm called the chiasmatic recess. Below the chiasm is the infundibular recess, and the infundibulum, which is the pituitary stalk, is somewhere around here. So when you're doing this procedure, it's very important not to poke close to any of these cisterns and recesses. You want to stay away from the recesses. And so the floor of the third ventricle is a very thin membrane that is made up of ventricular ependyma and cisternal walls. And this floor of the third ventricle is called the tuber cinerarium. And the other side of the tuber cinerarium is the prepontine cistern. So the goal of the endoscopic third ventriculostomy is to connect the ventricular system to the subarachnoid space. In other words, to connect the third ventricle to the prepontine cistern. Here is the mammillary body of the hypothalamus. And so the ideal location for performing an endoscopic third ventriculostomy is to protect all the key eloquent structures within the third ventricle, and it is to poke directly in front of the mammillary bodies. And in that way, you'll preserve this chiasm, you'll preserve the infundibulum. And there are a number of different ways to do it. There are some blunt probes that come with the endoscopic set that you could just open the floor of the third ventricle with. And if the floor of the third ventricle is tenacious and scarred down, then you could open it up with some graspers. The reason to be delicate here is because directly on the other side in the prepontine cistern lies the basilar artery and all of its key perforators. So it's important to take your time and gently go through layer by layer of the tuber cinerarium to get safe opening into the prepontine cistern. So we performed a biopsy, and the biopsy came back as a germinoma, and we sent the patient for radiation. This was a case I just did recently, so I don't have long-term follow-up with respect to outcome after radiation, but I'm just as curious as you are to see what the result will be 6 months from now. So with that, I'm going to stop. I have another endovascular case, but I just wanted to stop here and see if you had any questions that I may be able to answer.
Dr. Miguel has a question. He thank you for the lecture, and he says, in case of pineal germinoma, while during the ETV and biopsy, the tumor may bleed. So, do you put an EVD? And in your experience, is it more sensible to obtain the CSF from the ventricular puncture, or a CSF from lumbar puncture to obtain the markers that you talk about?
So that's a very good question, and we thought about all of those considerations. And so one of the benefits of doing the endoscopic procedure is you're going to be in the ventricular space. So it is better to avoid doing a ventricular lumbar puncture in the setting of obstructive hydrocephalus. So if you're going to be there endoscopically, then you can send the CSF at that time. Secondly, the germinoma, it's a very bland tumor. It looks like a pearly appearance, and it appears white. This was very, very bland, the tumor. We took a number of samples, and there was no bleeding. But we always leave a ventriculostomy behind, just in case there is any bleeding, because a ventriculostomy can help divert the CSF and safeguard from intraventricular hemorrhage.
I hope, Dr. Miguel, that answers your question. If you have a tumor bleed, you normally leave an EVD. But how concerned are you about the ETV, the ventriculostomy that you've done?
Yeah, you worry about it, but we leave it clamped. We get a scan immediately after the procedure, and if there is no hemorrhage, then you just leave the ventriculostomy clamped, and then you take it out the day after. If there is blood, then you leave it open. And one of the risks or potential pitfalls of opening up the ventriculostomy is that the ETV may scar down and may not be as beneficial. But in this case, we didn't have to do that. We just left it clamped. We took it out the next day. And we'll see, if his hydrocephalus resolves with radiotherapy.
And do you do septum pellucidotomies as well in all of your ETVs, or do you select cases?
Yeah, so septum pellucidotomy, we don't do it routinely, although it is a good thought. The septum pellucidotomy, I think, is more practical for somebody who has a colloid cyst, because both frontal horns of the ventricle are dilated, and if you put them in communication, you can potentially reduce the rate of ventriculoperitoneal shunting.
Thank you, Dr. Rimal, for your excellent presentation and cases with these excellent outcome. We thank you for your time.
Thank you.
We would like to have you in the future as well, if possible. And now I would like to end this session, and we'll have you. We'll have another session next week, and we'll be discussing posterior cerebral arteries. Thank you all for joining. Thank you, Dr. Rimal, for your time. It was a pleasure to have you on board.
Thank you so much. Thank you. Good luck to everyone.